Good evening, everyone. So I'm Alexander Kotlyar. I'm one of the fertility specialists at Genesis, and I see many patients with endometriosis, and often handle the medical and surgical treatment of endometriosis, especially in the context of fertility treatment. So the title of this talk is Endometriosis: What You Need to Know. So the first question: what is endometriosis? It's defined as the presence of endometrial tissue outside the uterus, the endometrium being the inner lining of the uterus. And suspicion for endometriosis often comes up if women have painful periods, very classically, or other pain syndromes, pain during intercourse, pain with bowel movements, pain in between periods, and infertility without obvious causes, which we often call unexplained infertility. So in general, 20% of patients with infertility are unexplained. As far as how often we see it, how prevalent it is, about 5 to 10% of reproductive age women have endometriosis. Unfortunately, the diagnosis often takes a long while because it can be confused for other pain syndromes, or, and this is most unfortunate, dismissed as just painful periods, which shouldn't be the case. And over the past several years, a more proactive approach has been taken with any sort of pain symptoms that women are having, so that they're not spending this long amount of time, years on end, before they have any diagnosis or have the chance to be diagnosed with endometriosis. In women with pelvic pain in general, about 50 to 60% of them will have endometriosis of some form. For those with infertility, a substantial portion will have endometriosis of some stage, so 30 to 50%. Now arises the question, well, how does endometriosis come up? What's the pathophysiology of it? The most common theory behind why endometriosis arises is something called Samson's theory. It's that of retrograde menstruation. So menstruation is commonly viewed as blood and endometrial tissue going through the cervix. Well, actually, in about 90% of women, it also goes the opposite way through the tubes. And some of the tissue ends up in the belly. For the vast majority of women, this tissue doesn't do anything and the body reabsorbs it. But then for some women, it seems to stick around and cause issues, namely endometriosis. Based upon various other studies and lots of great research, some of which I've been privileged to be a part of, there are other theories that have come up, such as the stem cell theory, so trafficking of cells from bone marrow, from other supportive tissues. You can even have transformation of tissues that are not gynecologic. Like, for example, endometriosis has been found in the chest cavity, which is closed off completely from the uterus, from the pelvis. And these endometrial cells have also been seen in blood vessels and in lymph vessels too. So they can spread through that route. This depicts the stem cell trafficking that can happen from endometrial lesions, which are shown on the right side of the figure, and from various other supportive tissues, we term mesenchymal tissues, and they can circulate from the lesions to the uterus and vice versa. This actually comes from a paper that I published with some of my colleagues several years ago. Is there any genetic link? It's highly suspected, in that we see this more often in families. If the mother has it, higher chance a daughter will have it. Or if a sister has it, her sister may also have it. As far as finding an exact gene, that has not been successful. Several genes have been implicated, but none really show a high a high number in these in patients with endometriosis. There's newer research looking into epigenetics. We have the DNA code, all the letters that make up our genetic code, but you can have little additions, little modifications, kind of imagine like little decorations on the DNA that affect how the DNA is expressed. And there's more and more research showing that there are some differences in some of those DNA decorations in women with endometriosis compared to others. So now when a patient has symptoms and we suspect it, how do we officially diagnose it? So as mentioned, there's a strong push to have a high suspicion for endometriosis with any chronic pain or any signs of pain, especially with periods, painful intercourse, or pain with bowel movements or urination. Once there's suspicion, an exam should be done. Initially a routine gynecologic exam. There could be tenderness on a manual exam. There could be tenderness just with placing the speculum, especially if a patient seems very sensitive with any part of the exam, and you've excluded other causes like infection or just general aversion. Then you should also suspect some aspect of endometriosis. And on exam, you can note little nodules or areas where endometriosis has formed. They feel like little pebbles sometimes. And depending upon where the endometriosis is, sometimes it ends up on the ovaries or near the tubes, and you can feel these large cysts that have endometriosis in them. We call them endometriomas. As far as imaging, the next step after an exam, even if nothing is found, is to do an ultrasound. And depending upon what type of endometriosis is there, especially if there's ovarian endometriosis, ultrasound can be pretty good at finding these manifestations of endometriosis. In some situations where it's less clear, MRI is also really good. There have been lots of studies looking at blood markers of endometriosis. One old one that's been thoroughly studied, you may hear about it, or your primary care doctor or your OBGYN may consider testing for it, is something called CA125. It's produced by endometrial tissue, but many other conditions can elevate it. So it's not really a great marker. And thus far, we haven't found a consistent and really good blood marker that we're comfortable spreading to the clinic. Although there are clinical trials on multiple markers ongoing, but nothing has really hit prime time. The gold standard, especially if there's enough suspicion, is to do a diagnostic laparoscopy. And in that procedure, we put a camera into the belly under full anesthesia, and we can take a very thorough survey looking around. And not only could it be diagnostic, it would be therapeutic in that if we find endometriosis, we can remove it and also reestablish normal anatomy. So either endometriosis is diagnosed after that whole progression that we just discussed, or even if it isn't diagnosed conclusively, then it's not unreasonable to start treatment. And just one sidebar. So the gold standard diagnosis, once again, is surgery, and that's when if you find an area that looks suspicious for endometriosis, you can biopsy it, and the pathologist says about a week or two later that what you biopsied shows endometriosis. Even if those biopsies don't show any of it, it doesn't 100% exclude the presence of microscopic endometriosis. So that's why, even if it's not officially diagnosed, if the symptoms are suspicious enough, we can still proceed with treatment. Now, the first line treatment is with oral medications. We call them non-steroidal anti-inflammatory medications. A common one is ibuprofen. There's also naproxen, and some studies indicate that it could be beneficial. Others have not really seen a big difference, but it's always a good initial step forward because the science of how pain works and what pain molecules are released. These medications, these non-steroidal anti-inflammatory drugs, are very good at knocking down those pain molecules. We call them prostaglandins. The reason why these medications may not work in some patients is because it may depend upon how bad the endometriosis is, if there are any other pain syndromes going on. So multiple factors, but nonetheless, medications like ibuprofen and naproxen are very good initial starting points. Oftentimes, a patient is placed on birth control pills, um, or progestins. Birth control pills have a form of estrogen and a progestin in them, or you can just do the progestin by itself. And progestins, they're a synthetic version of progesterone, which is what is made by the body. And the reason why birth control pills and progestins are so effective is because endometriosis, it's an estrogen dependent condition. And by taking excess estrogen, and it will sound counterintuitive, and that's very, very normal to think that, but I'll explain how it works. So, endometriosis being an estrogen-dependent condition, by taking these birth control pills, you're actually suppressing the hormones that build up, that lead to production of one's own estrogen. In addition, the progestin portion helps suppress the endometriosis cells. And the ingredients in birth control pills can also suppress some of those pain molecules. So a multifactorial benefit from birth control pills. When they're prescribed, classically birth control pills are prescribed monthly. There's a 20-day pack, with the last 7 days being placebo pills. For the treatment of endometriosis, they can actually be taken continuously, so 3 months on end, for example. And in numerous studies, many patients experience substantial benefit, at least a 50% benefit or more. Now, as far as the risks benefits of birth control pills, so the biggest risk with any extra estrogen that you're getting is you could have a very tiny risk of a blood clot. But when you think about that risk, it's a change of 1 in 1,000 without these birth control pills to 2 to 3 out of 1,000 with them. So it's a minuscule change, and patients can experience anywhere from a 50 to 60% improvement in their pain and quality of life. So in weighing risks benefits, unless a patient has a personal or family history of blood clots, the vast majority of women will stand to benefit from these birth control pills. Now on to the question as to, well, these birth control pills, they have estrogen, but endometriosis is an estrogen-dependent disease. The whole thought as to why you can get away with the estrogen birth control pills is that while they do give you some estrogen, it's not high enough to reach a threshold where the endometriosis starts growing. Let me give you an example. When a woman is not on birth control pills, her estrogen can climb up to 200 or 300. But while on birth control pills, the estrogen itself doesn't go past a much lower level, like say 40 or 50, and oftentimes even lower, especially with low dose versions. and that's called the estrogen threshold hypothesis. And 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 that hypothesis does indeed seem to hold true clinically. As far as progestins, once again, these are derivatives of progesterone. There are multiple options, some of which are oral, like Provera, that can be taken in high dose on a daily basis. You can also take Depo-Provera, which is a 3-month injection that's often used for very effective birth control, but can also be beneficial for endometriosis. There's also norethindrone or Netta, taken in high doses, Megace, which is often used for other indications, but is also a very effective progestin, and also intrauterine devices, IUDs, especially for patients that have that just have pain with their periods. The IUDs can not only stop their periods, especially over long-term treatment, with about 50% of patients experiencing complete stoppage of their periods for at the 6-month mark. And in addition to stopping the periods, it can lead to substantial improvements in pain. Once again, oftentimes with 50% or better response rates. If those don't work, or for some reason patients just aren't amenable to birth control pills or daily oral medications or the Depo-Provera injection, there are more powerful medications that can completely suppress or nearly suppress the body's ability to produce estrogen, and these are called gonadotropin-releasing hormone analogs. The common one used in the U.S. is Lupron or Leuprolide. The way that it works is it acts on the level of the pituitary, and it suppresses the hormones coming from the pituitary that stimulate the ovaries that lead to follicle growth and estrogen production. And it leads to a very low estrogen state. Also, very, very effective, and somewhat more effective than birth control pills. And one misconception that I want to emphasize, because I think that could be a stumbling block for many patients when they consider them. Use of these medications has been, I'd say, incorrectly described as leading to a fake menopause state. That is, it's not really true. Menopause is a situation where there's low estrogen, but your pituitary hormones are high. These medications shut down everything, but I emphasize only temporarily, and for the sake of quality of life and relief from pain, they can provide very effective temporary relief, and many patients benefit from them. The biggest side effects are low estrogen side effects, namely hot flashes, vaginal dryness, and over the long term, especially like after years on end of treatment, small decreases in bone density. This can be prevented or reduced when patients take a little bit of estrogen back in the form of, we call it add-back therapy. And one common agent that does that is norethindrone. It's a progestin that we mentioned earlier. So when patients take these medications, it often comes in the form of a monthly injection or a 3-month injection. And every single day they take this norethindrone, which is FDA approved for add-back therapy, just to reduce or eliminate these side effects. Another really like third line medications is danazol. It's a derivative of testosterone, and its role is also to reduce estrogen and to also deprive the endometriosis of the estrogen that it needs to thrive. And patients often use this when they've exhausted the other options, or if they don't want to go to surgery, which we'll cover shortly. And when they take this medication, they can have substantial improvements in their pain, but some noticeable side effects. Some patients, a minority, but some do experience a little bit of weight gain, but more importantly, we call it hyperandrogenic symptoms. So symptoms of elevated male hormones like acne, oily skin, thickened hair growth, and it can also affect your cholesterol too. Now, in addition to all those medical therapies, surgery can also be used. And as mentioned, surgery can be diagnostic and therapeutic. So if we're going in there looking for endometriosis, if we see any spots of endometriosis in the belly, then we can remove it. If we see it on the ovaries, we can take out the endometriosis cysts, those endometriomas. And we can also stage patients and just give ourselves a way of describing and characterizing the extent of endometriosis. In addition to removing these lesions, endometriosis surgery can also play a role in attempting to improve fertility in patients with endometriosis. So, as a consequence of these endometrial cells in the belly, they can lead to inflammation. They can lead to scar tissue formation. That can affect the ovaries. That can affect the tubes. It can affect ovulation and the ability of the tubes to normally function. When you do the surgery, you can break up some of that scar tissue and, as we term it, reestablish normal anatomy. And surgery has been shown to have an independent benefit as far as improving the chance of pregnancy in women with endometriosis in general. If the endometriosis is high stage, if there's scar tissue everywhere, then it's less effective. But especially in the milder versions, it can be quite effective. Now, after surgery, if a patient is not planning on conceiving, then it's important that you be started on one of the forms of medical therapy, as mentioned before, because even over as little as 2 years, but especially after 5 years, there's a high risk of recurrence, as much as 70% at that point. Going on the topic of inflammation, over the past few years, endometriosis has been seen more and more as much more of a global systemic disease. This is from that same paper that I wrote with my colleagues several years back, depicting how inflammatory factors that we know are upregulated in women with endometriosis have been found circulating throughout the body. And these come in the form of cytokines, so signals that immune cells send to each other, special pieces of genetic material, RNAs, that can circulate throughout the body, and stem cells too. So going full circle, people have considered endometriosis as a gynecologic disease, but really it's more of a systemic disease. And not only does it manifest as pelvic pain, but it can dramatically affect so many aspects of a woman's daily life and just her general well-being. And hence, that stresses the need to treat it as seriously as possible. So when there's pelvic pain, it behooves a provider to be very proactive and aggressive in examining it, listening to the patient, and treating it as soon as possible. On that note, what does the future hold? So there's lots of research trying to develop better non-invasive diagnostic tools. Back where I did fellowship at Yale, they're developing tools to use serum markers, namely these these microRNAs, to see if they can better diagnose patients with endometriosis, and initial findings are quite promising. As far as what therapy to best use for a patient, whether it's birth control pills, progestins, or if they should just go straight to those GnRH analogs like Lupron, There's more research looking at typing of a patient's endometriosis to do more tailored therapy. And there's also some ongoing data, but I will admit, very slowly moving data on finding other therapeutic options. And I'll give you an example. So I'm currently working with a company that's looking at a certain class of anti-inflammatory medications that are commonly used for the treatment of lupus and rheumatoid arthritis to see if it can be useful for treating endometriosis. Preliminary data is promising, but we just need more clinical trials. Any questions at this point? Adenomyosis also causes pain just like endometriosis, and they're considered related conditions. And it can affect fertility also. So in that regard, those are serious concerns for patients. I consider it a serious, significant condition, especially if it's affecting a woman's quality of life, or a patient's quality of life, and her ability to get pregnant. So a patient absolutely can get pregnant. It just depends upon the extent of the adenomyosis and just what her attempts at pregnancy have been. I guarantee you there are lots of women with adenomyosis getting pregnant right now and having nice, healthy pregnancies. But say if a patient is having trouble, then treatment with the same medications used for endometriosis can also be very effective for adenomyosis. And after a relatively short treatment course, they may tend to have some benefit. Now, as far as surgery, there have been very limited reports of surgical excision of adenomyosis and pregnancies afterwards, but no big clinical trials have been done. But bottom line, with adenomyosis, in general, you can still get pregnant. Still a very good question. So the classic sign is painful periods, consistent pain in between periods, or it could be just isolated pain with intercourse, pain with bowel movements. And in my mind, any sort of pain condition or constellation of pain symptoms that come up with any pelvic process or pelvic event or are localized to the pelvis should be suspicious for endometriosis. No, unequivocally no to both points. So if a patient comes in and she has a history very suspicious for endometriosis, and she wants to get pregnant, then depending upon how bad it might seem on imaging, that patient could certainly still get pregnant just with ovarian stimulation and IUI. And I've had many patients myself who've with prior history of endometriosis and more conservative treatments have worked for them. And I also want to emphasize that even if a couple has infertility and there's known endometriosis, it never means that the chance of pregnancy is zero. I remember one very stark case of a patient that had stage 4, very profound endometriosis, and she came to me because her surgeon wanted to do a very extensive surgery and was worried about potential damage to her ovaries, given how extensive the surgery would be. And lo and behold, after a single visit with me, she comes back saying, "Hey, I'm pregnant," and then everything went relatively smoothly for her. But the point I'm illustrating is, if a patient has endometriosis, or if their history is highly suspicious for endometriosis, they don't have to have a surgery. If they want a definitive diagnosis and possibly avoid medical therapy while trying to get pregnant, then surgery could be considered. Um, and even if they don't do the surgery, and especially if it's a low stage or low severity endometriosis, they if they haven't tried for a sufficient amount of time, they could still get pregnant. There are many women with endometriosis getting pregnant all the time. It's just that on average, they're more likely to have infertility. And if that's the case, conservative treatments like Clomid and IUI work fairly well over a few cycles. So yeah, and many patients do not end up needing IVF. I think there's a lot of promising stuff, especially with acupuncture. For example, like for IVF patients, there are some decent trials that have indicated improved pregnancy rates with acupuncture. So I take the approach of, if there's no harm involved, then patients can certainly go for it. I have no qualms whatsoever. Um, but at the same time, I think a global perspective needs to be taken, and a tandem approach with alternative therapies and with standard therapies, I think, should be considered. But yes, if a patient wants to go with acupuncture, and if it seems to help her, then I strongly encourage it. Generally it resolves following menopause, because it is an estrogen dependent disease. So with menopause, there's much less estrogen being produced. So the vast majority have resolution of their symptoms. That being said, there are some women who, even though the endometriosis may not be necessarily active, endometriosis, it's an insidious disease in that it can also lead to what's called central sensitization towards pain. And what that means is the endometriosis lesions over time can lead to buildup of pain fibers that make a woman more sensitive to any pain, or could lead to persistent pain signals. So even though, so some of those women, and I emphasize this is a minority of women with endometriosis, um, even after menopause, they could still have pain symptoms. But in general, it gets better, substantially better after menopause. Yes, especially if it's a certain type of endometriosis, and that's ovarian endometriosis. So they come up as these classic cysts that have this like frosty or snowy appearance, and very few other structures in the ovaries can mimic it. And I would say, in my experience, what I've seen virtually every single time I've diagnosed an endometrioma, an ovarian endometriosis cyst on ultrasound, if I've taken the patient to surgery, it's been endometriosis every single time. And the studies show that as far as those cysts, that form of endometriosis, um, there's an excellent correlation between those cysts being suspected for endometriosis and actually being endometriosis. There are other signs on a routine ultrasound that could hint at endometriosis, even if you don't see those cysts. If the uterus doesn't seem as mobile as it typically seems due to scar tissue, sometimes you can see even bits of bowel stuck to the uterus, and that could be suspicious too. But those are less clear-cut cases. That's an excellent question, because there's a whole zoo of treatments um, available for endometriosis. If a patient is not planning on getting pregnant, uh, so so NSAIDs like ibuprofen, naproxen, Birth control pills are a very common one, very effective. As many as 2/3 of women will experience improvement in their pain symptoms, and then other second or third line medications, like those GnRH analogs, like Lupron. And I also apologize. Like a new class came out over the past like 7 years or so. They're you could consider them oral versions of Lupron. The oldest one being elagolix, and then you'll hear of relugolix. Trade name for elagolix is Orilissa. Um, and they're also extremely effective, but they're limited by the low estrogen effects. So, and for both those medications, you shouldn't really use them for more than 2 years. So, in short, if a patient has endometriosis but they're not trying to get pregnant, there's a whole buffet of options that they can choose from. Yes, and that's what contributes to that's one factor that contributes to making this an enigmatic disease. I've done surgeries on patients where they had no symptoms, and then did an ultrasound which looked suspicious, and they had stage 4 endometriosis, scar tissue everywhere. It was very challenging. And then I've had other patients that have had very profound symptoms and like terrible periods. I go in there and they have a few tiny spots, but otherwise it's totally fine. Um, that's actually that's an excellent question. Um, but as an estrogen signaling disruptor, that that should actually be that theoretically should have a beneficial effect on endometriosis. The data whether endocrine disruptors could have an effect on the development or severity of endometriosis, to my knowledge, that research is still ongoing. But if it's affecting estrogen signaling and making it harder for estrogen to work, theoretically, it should have a slight beneficial effect. That being said, they're endocrine disruptors, they're estrogen disruptors. So I would say their any beneficial effect on endometriosis would be outweighed by a multitude of negative systemic effects. Terrific question. There's no data implicating any sorts of foods, per se. I mean, and if there's any diet that may be beneficial, it's the Mediterranean diet, which seems to address every medical issue under the sun. And that actually brings up another very important point. As far as lifestyle changes, exercise and having and maintaining a healthy weight, healthy diet, it has also been shown to be beneficial for patients with endometriosis. So it's not a food per se, but it definitely lifestyle. As the healthier one can make it, in general, the better patients with endometriosis feel.